Hi guys, it's Dr. Ron Miller here with cashbasedphysiotherapy.org, and today we're going to go over a complex case study. Okay, we're actually going to go over differential diagnosis of 3 different diagnoses, rule in and rule out pathologies, my thought process, and we're going to go over some clinical case studies because this is the second time I've seen this in my life. So what we're going to do is going to look at differential diagnosis first with frozen shoulder, adhesive capsulitis. We're going to look at thoracic outlet syndrome, and then we're going to look at a cervical radiculopathy. Okay, so let's look at because right now I have a patient who I feel has true frozen shoulder. Okay, but let's see how we diagnose this. Okay, so we know that frozen shoulder, we're not talking about true pathology of what is occurring, but in the clinic, what actually happens. Okay, so adhesive capsulitis, they'll have the capsular pattern. And my current patient has external rotation 15 degrees, all are painful. Internal rotation is 30, abduction is 60 degrees, all painful. Okay, they'll have the hard, painful end feels. Okay, and it's not responding well. Almost like the more you push, the harder it's pushing back on you. Okay, it's not responding fast, you would say. Okay, so capsular pattern, clinically, a novice clinician will diagnose adhesive capsulitis just looking at active range of motion, but a good clinician will actually differentiate between subscap hypertonicity versus true adhesive capsulitis. And when you treat the subscap, you don't get fast changes. That this is, my patient actually has true adhesive capsulitis. And again, we know there's 3 phases. There's the freezing, the frozen, and the thawing. Okay, so right now I have a patient that I feel presents with true adhesive capsulitis. Okay, next, thoracic outlet syndrome. Okay, there's 2 main types. Okay, we know there's a neurogenic and then there's a vascular. Okay, we know that 98% is neuro, well, I think 2% is vascular. Okay, vascular, you look at the Adson test and you look for the change in the heart rate when you compress the certain structures. Most of the stuff is going to be neuro related. Okay, and they're going to either be compressed at the scalenes, first rib, or the subclavicular space, and that's normally a pec minor problem. Okay, again, this is a harder diagnosis to make. You got to rule in and rule out red flags, any kind of Peyko's tumors on the left side and stuff like that. But all these diagnoses can cause intermittent symptoms that have intermittent radicular symptoms, shoulder pain, axilla pain, etc., and stuff like that, even neck pain, upper tract. Okay, your cervical radiculopathy. What if the current symptoms are coming from the spine? So I think it was Wayner did the CPR. Okay, you got your Sperling's test. You look at your rotation. You look at your upper limb tension test and the rotation degrees. I believe it's decreased rotation to the affected side. And then the distraction. Okay. Now, the cervical radiculopathy isn't really telling you whether you have a herniated disc or a facet. It's just saying that the radicular symptoms going into the upper extremity are from the cervical area. It could be discogenic, it could be facet, but normally I use the CPR for this, and anything 3 out of 4, you have a high probability or a likelihood that you have a cervical radiculopathy. Okay, so diagnosis wise, adhesive capsulitis, true adhesive capsulitis, clinically for us is an easy diagnosis. We know how this feels. Cervical radiculopathy, you should be able to treat that, diagnose it, and be able to treat it, okay? So the good thing about this is this responds great to McKenzie treatments on the neck, okay? To help validate this finding, if I treat the neck with McKenzie cervical retractions into full end range with overpressure going into extension, this responds great to McKenzie stuff, okay? Frozen shoulder, you know, the treatment of this, if you have true frozen shoulder, you know, the research actually supports one injection plus physical therapy. But again, you're looking at like a 3 to 4 month process with this, when the natural course of frozen shoulder may take 9 to 12 to 16 months if you don't do anything. But the research actually supports one injection in the intra-articular space plus doing PT, and maybe your outcome goes in 4 months, okay? But this is a long process with true frozen shoulder, okay? This is a question mark when it comes to treatment, okay? Especially for the neurogenic stuff, okay? So looking at some of these things here, let's go over a case example, okay? So right now, I have a patient that presents with severe shoulder pain, upper trap, tightness, and ache, and she has intermittent symptoms that are going down her arm. No specific pattern, just when she moves her shoulder certain ways, she causes intermittent complaints of pain that shoots down her arm, not numbness and tingling, okay? So the first 2 sessions, I treated her and wanted to see if she had true frozen shoulder, okay? She's high stress, works a lot, never really does anything for herself, had a shoulder injury roughly like 5 months ago, pushed through it and kept on going. And she presents with this severe loss of range of motion with these impairments, with shoulder pain, okay? I did 2 treatments, okay? Releasing subscap, staying within tolerance, light joint mobilizations, with really no change in symptoms, okay? I'm not making a true change, okay? So I was like, it started to get me questioning a little bit. What is going on here? Does she have true frozen shoulder? Is there something predisposing this? So I actually find that with my frozen shoulder patients, when I treat the neck and the shoulder, I get way better outcomes. So I actually started looking at the spine, doing an HVLAT plus some cervical treatments, okay? And the next 2 sessions, I did neck plus shoulder stuff, and I still was not making a change, okay? And when I did McKenzie stuff, I actually increased her shoulder pain, okay? Which got me really thinking about this a little bit, because normally my true frozen shoulder patients, they respond good to conservative care, releasing the subscap, gentle light range of motion, some passive range of motions to the shoulder, plus if I add in some rib, thoracic, and cervical treatments, they respond a lot quicker, okay? But in 4 treatment sessions, she's not responding the way I want, okay? And I looked at this, she comes up negative for the CPR for a cervical radiculopathy, okay? So she doesn't have referred pain necessarily like a cervical radic, but you know, when I do McKenzie treatment to the neck, it increases and reproduces her shoulder pain. She's just laying there supine. I'm doing manual cervical retractions, and it reproduces her pain. She feels it shooting right down to her shoulder, okay? So Another interesting finding here, okay, with thoracic outlet syndrome. Yeah, the common minor symptoms of just getting some postural related stuff with some shortness in the scalenes, first rib dysfunction, you know, minor cases, you can do a myofascial release and stretch and be done and they respond great. But I'm starting to wonder if she really has thoracic outlet syndrome first and this second. And one finding that I also see here is if you do, with true thoracic outlet patients, if you do cervical distraction, lift up, it makes symptoms worse. I've seen this once before with this kind of series, but when I was doing distraction, retraction, and extension, I'd increase her shoulder pain, okay? So I feel confident that it's not a cervical radiculopathy, but is it a neural tension problem, or does she have an underlying pathology of thoracic outlet that's been building up for a long period of time, thus causing the frozen shoulder? Okay, and it got me thinking, as I started to treat the neck and increased her shoulder pain, I started to think, does she really have thoracic outlet syndrome? Because when I added the distraction and retractions to her neck treatments, I actually started to increase her right shoulder pain. And it got me thinking again, does she have an underlying pathology of neurogenic? Something's being compressed, whether it's scalenes, first rib, pec minor, plus it's also positive cervical distraction. Okay, and some of these cases I'm starting to realize that they'll present, okay, besides my current case, you'll have a cervical radiculopathy textbook case that doesn't respond to treatment, and maybe they have like what you'll consider like a C8 herniation, really low cervical, shoots into the chest, axilla area sometimes, and maybe intermittent symptoms down the arm, but they don't respond to McKenzie in the cervical spine. Sometimes it's a true thoracic outlet case, and it's not a cervical radiculopathy case. And you got to start treating the scalenes, first rib, and pec minor and see if you can make a change to these symptoms. Okay. So I'm starting to think that her primary diagnosis is actually thoracic outlet with a secondary frozen shoulder. And I've seen this case once before in my life where there was a young 16-year-old athlete, shoulder injury, actually had thoracic outlet syndrome and frozen shoulder and CRPS, high anxiety, stress, misdiagnosed, bad PT cases. PT was bad and made things worse. It just went down this huge cyclic pattern of pain, chronic pain, and CRPS. And I saw her, I was able to get rid of her CRPS. I treat the frozen shoulder, but I plateaued. I never was able to get her above 90 degrees of abduction. And I kept on trying to treat scalenes, first rib, and pec minor. No matter what we did with the scalenes, nothing would calm the symptoms down. We did PT, we did chiro, we did massage, we did injections, we did Botox. Nothing really calmed these down. And then she ended up seeing a thoracic outlet specialist in Tampa, injected the scalenes with some sort of injection, showed a 50% reduction in symptoms, and then she was a candidate for surgery based off of his inclusion. So she actually had first rib removal surgery. And then when this was treated, we got back to this and her frozen shoulder resolved. Okay? So, what my question is, what I want to create an excellent discussion with this is, what are some evidence-based ways to treat true thoracic outlet syndrome? You know, should we be doing some nerve glides? What have you guys been doing to really treat the scalene muscles, first rib, pec minors? And don't just say stretches, because true thoracic outlet, you shouldn't be stretching necessarily at first, because a scap retraction may worsen symptoms, okay? But I want to get a good discussion going about thoracic outlet here. And what have you guys thought about or seen in the clinic that really helps people with true thoracic outlet syndrome when you're addressing the scalenes, first rib, and pec minor? What works for you guys, because I believe that this case has true thoracic outlet now with a secondary frozen shoulder. And if I keep treating the frozen shoulder, I'm not going to get anywhere because there's some underlying pathology that is going on, which I believe is thoracic outlet. Okay, so let me know your thoughts, questions, concerns. Put them in the comments box below. Let me know what you feel is working good for you for your thoracic outlet patients. Let me know if you have questions about the differential diagnoses, treatment options for each of these, and let's brainstorm together and see what really works for true thoracic outlet syndrome. And I'll try it, and I'll be able to report back to the group, and then hopefully we can calm this stuff down before I start treating the frozen shoulder, and then start making changes in pain, range of motion and stuff. So thanks for tuning in. Please put any comments on the comment box below, and I look forward to having a great discussion. Thanks.